Thank you for the opportunity to discuss this topic today. I have no disclosures. So just to quickly review what we all already know about congenital infantile hypertrophic pyloric stenosis. It occurs in about 2 to 5 out of 1,000 live births. It's more common in Caucasians and males. There can be a familial pattern, and the etiology is still unknown. There are guesses about infectious origins, cellular deficiencies, genomics basis, and even maternal medications and behaviors during pregnancy, but nothing has definitively been linked. The pathophysiology, as we know, is a postnatal hypertrophy, thickening and edema of the circular muscle. It's not hyperplasia. After treatment, the muscle becomes normal. If you operate on a patient who has had a pyloromyotomy, you cannot see the scar or any abnormality later. It does truly resolve. These babies usually present between 2 and 5 weeks of age, and they present with recurrent non-bilious vomiting, and the parents will tell you that they're hungry, ravenous after. They're usually dehydrated. Parents are concerned that they've been making less wet diapers. There can be weight loss, and it's a progressive disease. The differential diagnosis can include overfeeding, frequent formula changes, reflux, delayed gastric emptying, pylorospasm, even duodenal web or stenosis, and metabolic disorders. On exam, the baby will be dehydrated with a sunken fontanelle. The abdomen will be flat and decompressed, but there will be the pathognomonic olive or palpable mass in the upper abdomen. Workup includes checking labs and electrolytes, and the typical electrolyte abnormality is a hypokalemic, hypochloremic metabolic alkalosis from the repeated vomiting and gastric losses. And in this instant, you would also want to get some imaging to make the definitive diagnosis. If an X-ray is obtained, commonly what you'll see is an air or fluid-filled stomach that's very large and distended. And sometimes the X-ray findings can be confused for duodenal atresia because it can have that double bubble sign of a really large distended air-filled stomach. On ultrasound, what you'll see is a transverse pyloric thickness that's at least greater than 4 millimeters in the transverse dimension, demonstrated here, or greater than or equal to 15 millimeters in the length of the channel. So this is the stomach here, and this is the pyloric channel in the lengthwise. And here are some other images showing the transverse dimension of the pylorus. So here is the muscle here. This is the mucosal stripe. And again, this is the muscle thickness and the mucosal stripe in the center. If upper GI is obtained, what you'll see is a bulbous gastric outlet obstruction. And sometimes you can see, I don't know if you can make it out on this image, here's barely a faint stripe of contrast trying to go through the pylorus there. Similarly here and here, this sort of beaking appearance. So preoperative considerations, this is the most important part. This is not an emergency. These babies must be resuscitated before they can safely go to the operating room. Most important thing is to bolus them and then start them on maintenance fluids at either 1.5 or 2 times maintenance rate. And remember, even if their serum potassium level is normal, they actually are hypokalemic at the intracellular level, so they do need potassium replacement in their fluids. And then recheck their electrolytes frequently until the resuscitation goals are met. What are the resuscitation goals? You want to see urine output at least or greater than 2 mLs per kilo per hour, and of course, normalization of electrolytes. This is also very important because the pediatricians will ask, can the baby eat? Do not let the baby eat. It will only lead to continued vomiting and continued electrolyte abnormalities. The other question is, should we place an NG? I think that's surgeon specific. I personally do place an NG. Why? To decompress the stomach, decrease the risk of aspiration, and then recheck the electrolytes often until they're normalized. Anesthesia considerations. This is what the anesthesiologists are going to want to see before they'll put the baby to sleep. They're going to want to see the chloride normalized and the bicarb less than 30. Why? Because it increases the risk of apnea and extubation difficulties. Also, they're going to want the stomach emptied prior to intubation. So often in the OR, they'll, with the baby awake, suction out the stomach with an OG tube, and this decreases the risk of aspiration. So pitfalls: allowing the baby to continue to eat, inadequate resuscitation, rushing to the OR, not correcting the bicarb less than 30, and not emptying the stomach prior to induction. So operative treatment is the pyloromyotomy. This shows you a cartoon of the transection of a normal pylorus, and here is in the instance of hypertrophic pyloric stenosis. And so the object is to incise the pylorus on one side so that you get an open channel, demonstrated here. So the Ramstead pyloromyotomy, named for the surgeon who first tried this maneuver and then described it, involves a transverse incision in the muscle from the vein of Mayo to the duodenum. Then you split and widen down to the mucosa. And then you want to move the two sides of the muscle independently. Now here, when I'm doing this maneuver, is where I say the enemy of good is better, because the tendency is to want to keep going, keep going, keep going, and that's when you're going to run into trouble and potentially get a perforation. Open versus laparoscopic procedure. The open procedure, there's two typical ways to do it. One is a right upper quadrant transverse incision, and the second is an umbilical incision where you make a skin incision, tunnel up the linea alba, and then open the fascia in the upper abdomen and deliver the pylorus through your fascial incision. The laparoscopic technique involves 3 trocar sites, has better cosmesis, usually a shorter OR time, around 15 minutes, has a shorter time to feeds, less post-op analgesia, and shorter hospital stay. Initially, when the laparoscopic technique came out, it was associated with an increased rate of incomplete myotomy. This has decreased over time. But the leak rate between open and laparoscopic is the same. So which technique should you do? Whichever one you feel comfortable and competent performing. Both are acceptable. And if you're not comfortable doing either, that's when you should consider transferring to a pediatric center. At the end of the myotomy, you can do a leak test where you occlude the duodenum and you have the anesthesia team inject air through the gastric tube. And then you look for bubbles on the mucosa through the myotomy. It's not perfect, but it is reassuring if you do the leak test and you don't see any bubbles. So pitfalls in the OR can be dissecting too far on the gastric side where the muscle is normal thickness, dissecting too far on the duodenal side, or not splitting all the muscle fibers over the mucosa. So in essence, not being aggressive enough or being too aggressive. So here are some images from the laparoscopic technique. So here you can see the 2 instruments are demonstrating the 2 shoulder edge of the hypertrophic muscle. Here the muscle's been incised. And you can see in the incision that the muscle is still white, so that's how you know you're still in the muscle. And here it's been split down to the mucosa, demonstrated by the pink mucosa at the base of the incision. And here the duodenum is being occluded, the stomach is filled with air, and we see no bubbles coming from the mucosa. And these are just some photos demonstrating the difference between the open scar and the laparoscopic. So complications, you can get a mucosal perforation and leak. That can be immediately recognized or delayed, incomplete myotomy, and wound infection. Mucosal leak, again, it's a pretty low incidence, around 1% or so, and open versus laparoscopic has the same rate. If you recognize it intraoperatively, then you can close the myotomy over the mucosa. You can patch with omentum if you like, and then the typical teaching is turn 180 degrees, but in reality, turn to wherever you can safely redo the myotomy. If you do get a perforation, again, it's usually on the duodenal side as you're trying to get your myotomy and splitting better. Delayed presentation of mucosal leak. The baby will have vomiting, but also distension and signs of sepsis. And in this case, it dictates an immediate return to the OR, in which case you're going to repair and do damage control. And the mortality associated with this delayed presentation is less than 0.4%. So it's low, but it's there. So pitfall would be a patient with persistent vomiting, abdominal distension, lethargy, they're inconsolable, and with some vital signs abnormality or unstable, and not recognizing that this is a mucosal leak and requires immediate return to OR. And if you're not at a children's center, this would be a time to strongly consider transferring to a pediatric center. So incomplete myotomy presents with persistent vomiting, usually persisting up to 1 week after the procedure. At this point, it would be indicated to get repeat imaging. Ultrasound is likely not going to be helpful because it's just going to show still a thickened pylorus, and you're not really going to be able to tell exactly what's going on. So usually an upper GI is going to be the study of choice, and you'll see that there's no fluid passing out of the stomach, and that's going to be your clue that it's an incomplete myotomy and warrants going back to the OR. The question here has come up, should you try atropine? There's really no good evidence. There are a few case reports, and the success rate is not overwhelming. So really the gold standard for this would be a repeat myotomy. So pitfall here would be persistent vomiting post-op, no signs of sepsis, but not recognizing that it's an incomplete myotomy. So if 5 to 7 days after persistent vomiting, that would be the time to consider re-imaging. And if you're not at a children's center, this would be a time to consider transferring. So postoperative management, there are a million different ways to feed the children after surgery. Are you going to do immediate feeds? Are you going to do delayed? Are you going to let them start with partial feeds? Are you going to let them do ad lib? The best data that we have comes from randomized control trials showing that full ad lib feeds a few hours post-op show that the babies reach their goal faster and have a shorter stay, but do initially have more emesis. The other question is, do you start with Pedialyte? Do you start with formula? I don't think there's much difference with that. Post-op vomiting, there is some evidence to suggest that it can be predicted by the degree of their preoperative electrolyte derangement and as well as their lower weight on admission. So that can maybe help you in counseling parents for what they can expect post-op. So pitfalls with postoperative feeding, you should expect some emesis, but it should resolve prior to discharge. And if it doesn't, that would be the time to consider imaging. But you shouldn't send a baby home from the operation still vomiting with feeds. And at that point, if you're not comfortable and you're not at a children's center, that would be the time to consider transferring. So the question about non-operative treatment for pyloric myotomy, or like we said, failed myotomy, and the use of atropine. There's really not very good evidence to support. It's very low-level evidence, no randomized control trials, and probably some selection bias introduced into those studies. The best recommendation to come out of a review of all of the literature is that atropine non-operatively should be used for high-risk patients in an area where it would be really unsafe to have neonatal surgery done. And there's nowhere to transfer to a safe center. So we're talking, probably very remote areas, countries, et cetera. And one thing to keep in mind with using atropine is a negative predictive factor for if it's going to work or not is if they have persistent vomiting 3 days after you're starting it. That's probably a sign it's not going to be successful. So in summary, safe practices for pyloromyotomy: once the diagnosis is made, resuscitate until the electrolytes and the bicarb are normal. Do not allow the baby to continue to eat. Gastric decompression should be used to reduce the risk of aspiration prior to anesthesia. Perform the myotomy using the technique you're comfortable with, but making sure that all the muscle fibers are split, the two sides move independently, and don't go too far. The leak test at the end can be reassuring. You can do whatever postoperative feeding regimen you like, but if there's postoperative emesis that doesn't resolve, it does warrant further imaging. And if at any point you're not feeling comfortable with the course, then consider transferring to a pediatric center. Oh, whoops, wrong direction. All right, there are the references. Thank you very much.